Okay. You guys look very prepared over there at table 4. You've been sitting there like we've got this handled. So let's hear from you. Maybe your first recommendation from table 4 or any other thought-provoking idea that you think is the most important thing to share with us first. Okay, I see Raphael, the moderator, is going to give that one to us because the rest of you were very shyly all threw your hands into your lap. So that's fine for number 1. As we get back to you, we hope that the advocates for that point will be the ones that share. Okay.
Well, there was supposed to be no rapporteur in, so
Right.
I guess I'm playing that role again. So a very interesting discussion, and I think that some of the highlights that I can sort of capture in a few seconds. A strong focus on strengthening local capacities and community preparedness, especially through a strong emphasis on exercising and including in that process a broad set of stakeholders and community actors to build community resilience and capacity to prepare and respond to outbreaks. But in that process, using, for instance, templates or approaches that have been developed, such as influenza, which covers a number of key elements that will be critical to strengthening those local capacities, but also taking into account a broader public health perspective and making sure that approach is also flexible and adaptable to other kinds of outbreaks or situations that are closer to that community. Also, paying a lot of attention to coalition building and making sure that this brings actors beyond the health sector and engaging with local politicians and decision makers to communicate the benefits, the returns that such investment would have on that particular community. And lastly, also paying attention to messaging in terms of communicating and raising awareness about the potential impact of outbreaks on local communities, but also making sure that some of the potential negative frames that are often used to communicate about outbreaks can be addressed through positive framings. For instance, the example that was used was if there is vaccine failure, to focus more on lives saved as opposed to the failure itself. But again, something that is very concerning given the ease with which some of the negative frames can be amplified through different social media and the multiplicity of channels that are available today. So these are issues that were very concretely put on the table as actions and areas that need attention as we move forward.
Thank you. How about table 7?
Sure, I'll briefly summarize what we have and then...
Can you use the mic, Jen? We can't.
Strayed from me here. And then David and Eva will mention a little bit more. So we were largely focusing on how do you reduce the amplitude of the panic neglect cycle through panic preparedness. How do you prime politicians and institutions to respond to panic? And we talked about using simulations and exercises as a tool for this, and that this work needs to be very intersectoral, non-medical, medical, the military and security domain. And we also really need to recognize how risk is distributed unequally across the population. And maybe focus some of our early efforts on working with the healthcare worker community. But I'll let David and Eva speak a little bit more about both of these.
Yeah, my
thought. Sorry, can you introduce yourself for the transcriptionists as we go?
Sure, David Fiddler, Indiana University and Council on Foreign Relations. My recommendation was to embrace the panic. And to think about panic as part of the process. it perplexes me a little bit that we've been talking about panic and neglect as if global health is unique in experiencing this. Every policy area experiences this. But what I don't think has been focused on is the panic as a process, and to understand and study that process as a way to make sure that you never miss the opportunity to turn the crisis into something better. What we tend to do is we tend to think about what are the lessons learned from the last panic so that we don't have another one, as opposed to thinking about the panic as a process that we can study and explore to figure out how to do that better in working with politicians who have to make those panic decisions. I don't know that it even makes sense in my head, but I think we're missing the opportunity to look at the panic as a process that will help peg some of these interventions so that we reduce the political elasticity that we see in global health and make it more like other areas of policy, which has less, it's more inelastic with regards to that up and down, framework. But other policy areas experience this cycle too. Constant streams of money do not ensure good policy.
I was just going to mention two
Eva?
other points. One, we're talking embracing panic and kind of embracing community in the sense that, the community, we kind of talk about it as if it's one thing.
Introduce yourself.
Oh, who am I?
Yeah.
Oh, okay, sorry. Eva Harris, University of California, Berkeley. And so community is very, very heterogeneous, and in some countries, in some places is very, very already unified, in other places is completely fragmented, but there's always some level or some organizations that work within there. So the concept of kind of overall just recognizing that and trying to strengthen what already exists, and then maybe make more linkages to whether it's health or preparedness or whatnot. The other was just a plug for diagnostics, in the sense that we always talk about countermeasures starting at vaccines and drugs, but in fact, if you don't know the things there, you can't start. And so I've been involved a lot with WHO in different aspects, including my own lab, in developing new diagnostics, and then how do you get them out? So we need to deal with the fact that you need to include diagnostics in that triumvirate, which should be a triumvirate, including vaccines and diagnostics and drugs, et cetera. But you need to know it's there, and there has to be some way to kind of fund that and connect the dots, to be able to bring that in so that we can detect early, which is what everyone loves to say. But if you don't know what's coming and you can't recognize it, then, you can't develop any kind of countermeasure. So just kind of a plug for bringing that back into the picture.
Great. Let's go to table 6.
Jay Siegel. So one topic we discussed was whether we had adequate governmental organizational structure and leadership. I noted that in the area of food, drug, and vaccine and biologic safety and efficacy, responses to various episodes of disasters had over the decades led to the creation of an infrastructure that was able to deal with and prevent many of those problems. So, without going into details, but the tetanus outbreaks from diphtheria antiserum, and the food problems in the slaughterhouses, and the sulfonilamide disaster and the thalidomide disaster each gave rise to specific pieces of legislation that then got tweaked with gene therapy disaster and Rice syndrome and toxic shock syndrome and blood safety with HIV. So that raised the question I think Bruce asked, do we have the right infrastructure and leadership in place? We had some discussion about ASPR and BARDA and whether they're adequately resourced and staffed to drive behavioral changes down through government and through levels of government and through society that would be needed. But we also had discussions of community engagement, risk communications. Amanda, maybe you'd like to speak to risk communications? I hate to put you on the spot, but I know you have passion about it.
Oh, sorry. We were talking a lot about... sorry, I'm Amanda McClellan from Resolve to Save Lives. We were talking a lot about policy and legislation and connection of organizations, and I was just bringing up the point that I think, at least in terms of the US, it's much more robust than the types of systems I'm working in. My concern here would be about your risk communications and social cohesion, and what you would do here in the US in terms of planning your risk communications all the way down to community level, where social media plays such a large role, and that I would see that as a major risk that would need to be dealt with as preparedness that doesn't necessarily come from legislation.
Okay, how about table 1?
Hi, it's Julie Pavlin here from the National Academies. We had a lot of discussion. We also talked about BARDA and about the capability of our institutions, and really wanted to look at maybe recreating, because I think it's been attempted in the past, an interagency broad organization here, at least in the U.S., that can pull together the different capabilities and that has the authority and has a budget and is sustainable and is expandable in times of international disaster, a FEMA-like model, perhaps, for preparedness and for response. And that also does have that international focus to it and that part of that response, and so it uses those. We also talked about our politicians and educating them on the risk, as others have mentioned, and to highlight that risk, and also the public and other governments that, the risk of seasonal flu is really very similar, or is much higher than a lot of these other emergencies that people think that they have. They have more people dying from this, so let's use this platform. We can get vaccinations out to people using this platform. We can improve the knowledge and the risk, so that way if something pandemic comes along, we have that already. We have that knowledge base and we have that capability. Any other summaries from that?
You guys are good? All right, go ahead, Emily.
So at table 3, we spent a lot of time talking about local health departments and their capacity to surge when, in fact, at a lot of times in the U.S. and even in other industrialized settings, they don't even have the capacity to do their day-to-day work well. We thought that, so let alone surge for the extraordinary. So I think that in terms of day-to-day surveillance of infectious diseases, outbreak response, and then ending an outbreak and preventing outbreaks, what gets measured would get done. So if there happen to be metrics from the usual types of outbreaks that could be monitored and followed and resources applied to deficits, perhaps there would be better capability to respond to the extraordinary, and health departments would be better situated. We also talked about the need for some things like advanced overcoming the needs, for example, to buy Tamiflu in large quantities. Sometimes there's barriers to that when there's a big outbreak in country. Availability of vaccines beyond the supply in country where they're manufactured, sometimes very limited. And structural interventions to solve that would be useful.
Great. Anybody else from table 3? All right, 5.
So my name is Ashley Grant. I'm from the MITRE Corporation. And we had some of the same recommendations as table 1. So the FEMA model, there's fires and hurricanes each year, yet disease funding comes through supplemental funding that can take quite a while between the actual outbreak and having the money being spent. So we had the same recommendation. Some of the other things that we talked about at our table was linking global health security and domestic response, both in terms of messaging, and we think that would be a good thing to do. And one of the third things that we talked about is just overall healthcare in general across the nation and access to overall healthcare. And just by increasing access and overall preventative care across our nation, we can somehow prevent some of these bigger outbreaks from happening or mitigate some of the bad things. So those were some of the 3 basic recommendations. Does anybody have anything to add?
Well, no, Carrie Harwood, University of Washington. We also talked about how just increasing the healthcare force to serve the basic needs of people would sort of build in the surge capacity that was needed. And then people would have, important things to do between the crises.
Great. All right, Elizabeth.
Okay, so I realize I'm the last one standing between the group and lunch, so.
But we're on time, so.
I'll try to make
Is your
this,
mic on? I can't tell.
Yes.
Okay.
I'll try to make this short. We had three primary recommendations, and this will be the third time that FEMA is mentioned, because one of the recommendations was to develop a playbook similar to what FEMA has that clearly outlines who does what and in what situation and what are the backup plans. So having clearly defined, you're the number one person, number two, number three, so that the leadership knows what their role is and knows when they'll be called in for the different situations. Emphasizing that the playbook needs to go beyond just the health response and that this needs to be more multi-sectoral and take a community as a whole type of response. We also, in conjunction with the playbook, it was mentioned that we should have some type of line of credit that was on reserve that could be used immediately, and it wouldn't take 6 months of appropriations negotiations to have access to funding. The second recommendation is at the local level, and to recommend that at the local level, the focus is on non-pharmaceutical interventions and things like infection prevention in school-age children, and making sure that some of those community level functions are well ingrained and serve other areas of infectious diseases as well, not just pandemic preparedness. And then also making sure that at the local level, they understand the concept of layered interventions and early antiviral use, as well as non-pharmaceutical interventions, and not to be waiting for what they don't have with a vaccine. And then the third recommendation goes back to Julie's comments about the private sector and the requirement for doing risk assessments and trying to make preparedness integrated into those business risk assessments.
Great.
Anybody want to add anything? Okay.
Good. All right. Well, we had some really good recommendations. Also, just some comments, right, about what we're missing. I don't know if we won't attribute to you without your permission you making those comments into recommendations, but I encourage you to think about that as we go through the rest of today. Anybody have anything you want to just throw out to the group that you feel got missed? You have a burning issue that wasn't covered? No? Okay, great. And I think we've heard some themes. Wow, the FEMA model. Yeah, we've got FEMA in the room, and the FEMA model was brought up multiple times. So I think that's a really excellent recommendation, that's strong. And then certainly a lot around the community and building up the healthcare workforce, supply chains, community interactions, including communications. So thank you for those great things. And we are back on time, Mr. Chairman.
Good job.